Hello everyone, today I'll be taking another VivaLive session with QQSphere on the subject of general surgery on the topic trauma, and the subtopic will be burns. So let's start.
Welcome to the examination. Let's start with a scenario related to our focus area today. You are in the emergency department and a patient presents with severe burns. What are the primary considerations in the initial assessment, particularly regarding the airway?
For burn assessment, we determine the depth, the total body surface area, and fluid resuscitation.
Okay, those are important considerations, but specifically addressing the airway maintenance I asked about, what immediate actions would you take if you suspect inhalation injury?
We will check for soot or airway edema.
Yes, those are key signs. Prompt intubation might be necessary. Now, concerning the pathophysiology of severe burns, what are the major systemic changes that occur in the first 24 hours?
I don't know, can you please explain?
In the first 24 hours, there's a significant fluid shift from the intravascular space to the tissues, leading to hypovolemic shock, along with an inflammatory response. You must prioritize fluid resuscitation. Let's move on to secondary survey. What are the key components of the secondary survey in a burn patient?
The key components of secondary survey in a burn patient is in a burn assessment is a rapid, thorough head-to-toe examination performed only after the primary survey, the ABCDE approach, is complete and the patient has been stabilized. It is to identify additional injuries, obtain detailed history, and determine the full extent of the burn of definitive care.
Excellent. You mentioned a detailed history. What specific details about the mechanism of the burn would be most valuable for managing the patient?
Any allergies that the patient might have, medications, past medical history, last meal, and events and environment, which determine the exact mechanism of injury.
Yes, that's a good outline for a surgical history, often remembered with the mnemonic sample. Now, going back to burn depth assessment, how would you differentiate between a partial thickness burn and a full thickness burn based on clinical features?
It can be superficial, partial, or full thickness burn. And the clinical features, can you please explain?
Briefly, partial thickness burns are typically painful, red, blistered, and have quick capillary refill. Full thickness burns, however, are often painless, leathery, white, or charred with no blanching. For our next concept, discuss the rule of nines in estimating total body surface area burned.
It is estimated using the Wallace rule of 9, which estimates the percentage of body surface area burned, under which the percentage of head and neck is 9%, upper extremities is 18%, a trunk a total of 36%, lower extremities a total of 36%, and then groin or perineum given 1%.
That's exactly right. The Wallace rule of nines is a good rapid estimation method. Just to be clear, when you say lower extremities total of 36%, you mean 18% per leg, correct?
Yes.
Now, once you have estimated the percentage of burn area, which formula would you typically use to calculate the fluid requirement for resuscitation over the next 24 hours?
We use Parkland formula for fluid resuscitation.
Yes, that's the standard formula. For the final question, could you outline the key components of that formula, how it's calculated, and what parameters you would use to monitor the effectiveness of the fluid resuscitation?
The Parkland formula is 4 ml into the weight of the patient into percentage of total body surface area of Ringer's lactate to be administered.
Excellent. And how do you monitor the response to ensure adequate resuscitation?
I don't know, can you please explain?
The effectiveness is assessed primarily by monitoring urine output, aiming for 0.5 to 1 ml per kilogram per hour in adults, along with heart rate, blood pressure, and mentation. We have covered airway, pathophysiology, secondary survey, estimation of burn area, fluid resuscitation, and monitoring. This concludes your examination. This information is for knowledge purposes only and is not medical advice or a diagnosis. Please always consult a healthcare professional for clinical care.